Yay.
Yeah, it's starting.
Fabulous. All right.
Sorry everyone, some technical difficulties. Thank you so much for your patience. I really appreciate it.
You've done an introduction stuff already. All right. Good evening, everyone. Thanks so much for
I have to watch
joining us this evening. We're just going to first of all like to acknowledge the land at which we're meeting here this evening on the Garden land, Adelaide PHN, and pay our respects to elders past, present, emerging, and particularly pay our respects to those who have cared for the land before us here today, and acknowledge and pay our respects to any Aboriginal, Torres Strait Islander people who may be with us here this evening. So we're just going to share this presentation now on the screen here, and I will ask everyone to go onto mute if you're not already. We're going to do a bit of an introduction as to who we've got in the room here with us at Adelaide PHN. So first of all, a very big thank you to Crystal. So we've got the dream team back again from 2020. So big thank you to Crystal Myers for hosting tonight through Adelaide PHN and for their continued support as part of the COVID response. We're going around the room. We've got Melanie Smith, and for those of you who don't know, Mel's joined as our lead GP liaison now in SA Health. We've recruited in a few other roles in the vaccine space of GP liaison, so we have Mel as our lead, and particularly in the COVID response. And Mel is going to be on the chat. Is that right, Mel? Yep. So there you go. Post your really difficult questions to Mel. She'll be able to respond. She's been doing a great job of responding to the GP liaison emails. And then we have Dr. Tom Dodd, who, of course, many of you would all know from last year's and from earlier this year as Clinical Services Director at SA Pathology, and has done an amazing job in keeping us safe through all of the testing here in the state and ramping it up through SA Pathology. So thank you, Tom. And then Chris Moy, who has transitioned now from being AMA SA President, who is now Vice President nationally of AMA, and is a wealth of all things Commonwealth and what's happening in the national space. So thank you, Chris, for being here. So everyone's, and we've also got Dr. Jenny Gould, who's online, and Jenny, as many of you may remember from 2020, has been leading our GP assessment team and doing an amazing job with many of you online who are also part of the GP assessment team, and been caring for our COVID positive patients in the state for the last 18 months. So thank you, Jenny, and we look forward to coming to your presentation soon. So everyone's very kindly offered to give a bit of an update as to where we're at, and no doubt we'll continue these webinars as we move forward in the next few months. So I'm going to start first of all with COVID-19 planning, and I won't talk too long in this space because there's some really great presentations tonight, and really we want enough time for question and answers as well. But I will start as to where we're up to with COVID-19 planning, and I think probably the emphasis here is around how do we have an integrated response moving forward. So many of you probably have seen webinars in other states, and particularly the webinars we've seen from New South Wales and Victoria. There's been some fantastic webinars around what has been the community response and how have all the different models of care, how they all sort of fit together in the in New South Wales and Victoria. So I'm going to give you a bit of a snapshot as to where we're heading here in South Australia. So we are moving towards a statewide model of care. And particularly, this is going to be influenced a lot by the modelling. So we talk a lot about Doherty modelling, but we are still waiting for the final modelling to come back into SA Health. But we've had a bit of a snapshot, but also we've had a lot of the preliminary data has been coming from New South Wales and Victoria around what sort of percentage of people can be managed safely in the community. So just to give a bit of a background, we set up a COVID primary care task force about 6 weeks ago now, which was between the PHNs, Country and Adelaide PHN, the RACGP, APRM, and Rural Doctors Association of South Australia to come together and talk about how we could do some planning better for the 2022 living with COVID strategy as we move forward. And so we put together a bit of a plan and a strategy as to where we see sort of COVID being managed in the community. And all of the lessons learned so far are that 95% of cases can actually be very safely managed within home-based care or supervised quarantine facilities. And really only 5% of people, now that we have such good rates of vaccination, we've just hit aiming for 70% this weekend of single doses here in the state. I think is that right? Or 80% this weekend, single dose 70%. I have to think. I was just sort of disappointed. I thought we'd get 80 by now. Anyway, but we do know that 95% of cases can be very safely managed in the home. So what we're very keen is to have a centralised model that enables our GP assessment team to expand, to be able to manage and assist in the management of COVID within the community, but link into the usual GP as much as possible, providing state-based care. And we've sort of taken a lot of the lessons learned from New South Wales in this space. So we've got some really clear principles that we were sort of working towards about how we wanted to create the, really just coming back to the central point of keeping the community safe. So when we look at the transition to living with COVID, you can see now this is national data. I didn't put our SA data in here. I've just put national data in here just so it was really clear where we had obtained this from. But essentially you can see where we're tracking towards our 70 and 80% vaccination and the actual second doses there. And you can see if you look on that purple line where we're sort of progressing to around about mid-November is where we appear to hit 80%. Now, noting that's 80% across the whole population, not LGA based, and we are very much of the opinion that we need to make sure our most vulnerable communities do have those high levels of vaccination, and we're not just looking at 90 and 95% in other communities and balancing that out with a lower target in other areas. So a very big thank you to all of the GPs, Commonwealth vaccine clinics, who have been absolutely critical for the rollout of the vaccines here in the state. This is our sort of our triangle model, and in many ways it's the main focus really is on that community home-based COVID-19 model of care. When we think about 85% of patients can be very safely managed, we anticipate about 10% will need some sort of supervised or supported COVID-19 care facility, and then the top 5% is the hospital care. And looking at this, we spent a lot of time talking about hospital beds, the focus of where the funding is currently. The big announcements have been in that top 5%. But what's really important, I think, to understand is that well and truly the majority of patients can be very safely managed in that bottom portion of the triangle. And vaccination, the monoclonal antibodies we know have been absolutely critical in New South Wales to be able to reduce down those ICU presentations as well. And if we look forward at our SA's integrated health response, what we put together, we're trying to see, and Mel has been doing a lot of work in this space around PPE ready practices and trying to get more PPE out to practices and fit testing. We're trying to support mainstream general practice as much as possible. It sounds kind of a bit awkward saying mainstream, and we haven't quite got the term. I mean, we've said mainstream because they're GPs that are not GP respiratory clinics, and they're GPs that have not necessarily developed additional infrastructure for COVID positive patients. So, and I'm just checking people can see the slides. We just had a couple of people post comments that hadn't seen the slides.
It's fine.
Yep, no,
Slides
just
are fine.
double checking.
Slides
Perfect.
are fine.
Wonderful, thank you. Thanks so much, everyone. Just want to double check that before I progress any further. So this picture here around the integrated health response really sort of maps out where we see things heading. Now, people said to me, oh, when are you going to step up this model of care? We have an incredibly well-functioning supervised quarantine model at the moment with our Tom's Court facility, and of course the great support of Jenny and her team in supporting all the COVID positive patients. But we can probably only have about 70 or so positive cases in that particular facility, and of course centralised, not in our rural regional areas. So a lot of work into how do we develop this model of care so that we can have as much care delivered in the home environment as possible. And we're developing our rapid response care team to be that central coordinated agency taking on board the lessons learned from New South Wales, and then how do we integrate better overall to ensure that the usual GPs are involved in care, but also how do we support usual GPs and respiratory ready GP clinics to be able to deliver care as well. And we're looking at different infrastructure type payments and PPE support as well for practices so that they can see patients in the living with COVID state. And we are working through those PPE suppliers as I mentioned. So I'll move on now to what sort of the features are of the model. It really is expanded what we're currently doing now in the Medi Hotel. We're looking at how we can have greater capacity within the hospital space, and particularly in the ICU area, noting I think we need around 65 to 70 beds within our ICU to support potential waves coming into the state with quite significant public health restrictions still. And as we move through around our model of care, making sure that we have it right in the regional, rural areas and all of those pathways coming in. And Peter has just been very helpful as part of our task force in what are some of those key areas in the regions around care and transport related to patients needing care. Probably the point I'll just pick on is these metropolitan and regional rapid assessment and treatment centres. So some of the really good lessons we picked up, particularly from the Royal Melbourne Hospital, has been their hospital in the home model that has had an additional component where people have been able to be assessed and treated in treatment centres, not going through their EDs, being separate. And there's quite a lot of work happening currently in that space, how we can set up these rapid assessment centres that enable people to have some fluids, the IV monoclonal antibodies, and then go back into the home environment. So that's sort of just been worked up at the moment, and we're hoping to have some more work in that space over the next few weeks. All right, so I'm going to move on. So where the rural response is really important, and having rapid assessment and treatment centres in our rural areas so that people can get treatment without having to come many, many hours into the city. So where does this leave us? And I think this is some really key figures to reflect upon, particularly where New South Wales was. We know that their fully vaccinated rate was only 3.3%, and Victoria in July 12.2%. So a mammoth effort to get where we are now currently with our vaccine rates here in the state. But if we reflect on that, we know that it has definitely been a factor, very low levels of vaccination when the initial spread occurred in both jurisdictions. So we're very grateful here that we've been able to stop the wave coming into the state at this point in time, because it gives us the best possible chance of being able to reduce the risk that this poses and for us. And I've shown this big graph, I think previously at one of the RACGP webinars around where we're currently sitting with our statistical area 3 coding. So this is mapping out the LGAs here, and this is the data from yesterday that just came through. So this data comes through from the Commonwealth, and then it's mapped out by our vaccine team to really show where our gaps are and where we need to increase our vaccine pop-up sites. And Playford has been an area that we're continuing to focus on, and it's good to see we've had a bit of an increase now in that LGA from around 30% now up to 41% in the last couple of weeks. So very, very pleasing to see this overall picture. But when we talk about 80% and reopening, you do need to reflect upon the fact that the LGAs we're still not seeing those high figures in the LGAs. We need to see consistent 80% across the board. That's very important for our response. Just 2 last little slides, and then we'll move along, so I don't spend too much time on this. But I was a little bit concerned about these figures that came through from some of our research that last week through to SA Health around concern about catching COVID. I think the fact that we had 60% of people not at all worried and not very worried about catching COVID last week was a little bit worrying, a little bit of a concern for me, given the fact that we are seeing an increase in cases interstate, and of course we're having almost daily presentations now, positive cases here for truck drivers. But we do have the 24% quite worried, the 9% very worried, and 6% really worried. But I just wanted to emphasise that we've not really seen a big change in this picture, and in fact, anything we're just sort of plateauing along over the last month. Concern about an outbreak here in South Australia as well. We're still people are not that worried about things. So 23% not very worried, and 5% not at all worried. And then overall, as we look at that figure, so we've got 28% there. The rest have some degree of worry and anxiety. So definitely people are concerned, but it is important that we drive up our vaccine rate as much as possible, but also provide support and understanding to the community. And just in terms of our vaccination gaps, I'd quite like to point out where we're heading. So Kangaroo Island, phenomenal job, thanks to many pop-up clinics that have been set up there over a period of time, but we're still sitting quite low on the APY lands at 26% fully vaccinated. So a lot of work currently happening both the Commonwealth and state level to try and increase those very important doses, and 79% in our greater than 70 population. So we know they are most at risk group, particularly of needing hospitalisation. So pleasing to see that quite good numbers in those areas. So that's really all in terms of updates. So hopefully that kept it nice and relatively short. But But now APY-land data is accurate. Now this is Commonwealth data that comes in, and it's often a week behind. But yes, this is the data coming through the air. So I've pulled our state data to try and keep this presentation as consistent as possible. I've just used Commonwealth data, as we do often get a bit of disconnect between the two. All right, so we'll progress along. Who would like? Tom, are you up next? I think that was the order we used to have. So I'll hand over to you. Thanks, Tom.
Thanks. Good evening, everyone. So what I would like to do is just provide you with a quick update on testing and where we're at now. So we'll just go on to the next slide. So in terms of what SA Pathology is currently doing is around 5,000 tests per day, and the turnaround time has got more and more efficient as we've gone along. So we're finishing 90% of those tests in under 10 hours. Actually, in some days it's close to 8 hours. And effectively, really 5,000 a day I regard as sort of idling speed for the laboratory now. So we're just comfortably putting through that work without any real challenge at all. So what we're planning around is when we start to have a kick up in the need for testing, particularly as the borders start to open, soften, I guess, once we hit that 80% vaccination mark, and we know there'll be a big demand for testing for people coming back into South Australia, and just general expectation of being able to access swabs around the community, particularly if we get a few cases. So we're planning to be able to comfortably do 12,000 swabs a day, which is pretty well easily achieved as well, bearing in mind that the private laboratories contribute another 20% of tests as well. And beyond that, so that we can manage any cluster events, we have preparations in place with additional people to collect swabs and process swabs, and scientific and technical staff to be able to manage beyond 20,000 swabs a day. To give you some context, during the Modbury outbreak, we peaked at around 17,000 swabs in SA Pathology per day, and then the private labs put on another sort of 4,000 or 5,000 as well. So I actually think our surge capacity is probably closer to, it might be close to 30,000 a day if we really needed to across the whole state, which is 17% is 1% of them, 17,000, 1% of the population. So it's a pretty good reserve capacity there. Go on to the next one. The other thing that was evident over time is we've had these rapid PCR gene experts in all the regional laboratories across the state, as well as in every metro hospital, and they've been very helpful in terms of getting quick turnaround times. But there's been some gaps just because of the distribution of the SA Pathology laboratories within the regional hospitals. So we're looking to plug some of those gaps. So we're rolling out progressively gene expert instruments into some of the other regional centres. So Kangaroo Island's now got an instrument on site. I think training's now underway. So we're going to place gene expert PCR instruments, which will give that 60-minute turnaround time in about 3 or 4 other locations across regional South Australia. So we've got really good coverage to support patients who are potentially symptomatic in the coming months. And the big thing, of course, is rapid antigen testing, and where do they sit in the testing options. So internationally, of course, they've been really, really important, where PCR tests have been of limited availability and the prevalence of COVID has been very high. To the next one, thanks. Rapid antigen testing tests they're good tests, but they're far from perfect. They're certainly less accurate than the PCR tests that we've all been accustomed to over the last 2 years. So if you have a swab now and you get a negative result, you can be pretty sure your patient does not have COVID. If you have a positive result on the PCR, it's pretty much guaranteed the patient has COVID. And the situation, even once we start opening up and seeing some COVID in the community, is still going to be a very low prevalence situation. And so the literature from a number of sources tells us that in those sort of prevalence environments, the sensitivity of the tests are sort of around that 70 to 80%. So if you've got a symptomatic patient and you do the test, there's maybe a 25%, 20% chance you'll have a false negative. And the same applies for asymptomatic patients, but in fact, it's less sensitive still. Of course, rapid antigen tests are immunoassays, so they detect viral protein, and so obviously there are phases in the infection when the viral load is relatively low, particularly in that very early phase of the infection, when you'll get false negatives. When you've got very high viral loads, the test is obviously more reliable. But it's really important to remember that it is an imperfect test, and so we're sort of just emphasising that at the moment. Specificity, they're actually pretty good, about 99% specific, but that also means that in a relatively low prevalence environment, even if there was 0.5% COVID circulating, which is probably where we might be at worst, you still get a significant number of false positives. So we've been doing testing now. We've done a couple of thousand tests, and what we've found is we've had out of that probably 4 false positives and at least 1 false negative. If you get a positive rapid antigen test result, you have to confirm that result with PCR. It's really an indicative test. So as I've mentioned, most of you would be aware that we introduced rapid antigen testing a few weeks ago for interstate and transcontinental truck drivers. So we've been testing at Yamba out on the Victorian border and at Taylor Bend sort of 24 hours a day, and have got some reasonably good experience now with using them. And they're actually relatively straightforward to do. I've got a quick video at the end just to show you. And the other group that we're now doing regular testing on are FIFO miners at the airport. The next phase really for us is starting to do training inside the hospital. So we've got a training team that are learning from our experience out at the airport, and they'll be beginning some training inside the teaching hospitals in Adelaide, and then for the regional sites, our regional laboratory teams are also being trained up. So what we anticipate will happen is that we'll have those staff train people in the hospitals, and then it'll be a sort of trainer model for your nursing staff and others in the hospital to become familiar with the tests. There'll also, of course, be opportunities to provide training for other members of the community, and obviously general practice as well. We've got a training video, and I'll let you have a quick look at that at the moment. It's important to remember right now, though, other than in these few settings, the use of rapid antigen testing is still prohibited by a direction. So we do not have widespread use of rapid antigen testing. Many people, of course, are getting very interested in this, and we know we have to now move along quite quickly to get the testing sort of training in place for the sort of clinical areas. So where might it be useful, particularly where PCR testing is not so convenient? It might have a place in remote settings to sort of augment PCR testing. Anywhere where you've got sort of confined groups of people, prisons and so forth, it could be a sort of an adjunct to PCR testing. And then the issue will be, how do we utilise it more widely across health facilities and nursing homes and so forth? So certainly what's happened in some locations, of course, it's been used on a sort of a daily or every second day basis for staff, or particularly for patient groups. One possibility where it might prove quite useful is where you have staff members who are contacts of COVID cases, but obviously we don't want to be furloughing causing, making everyone isolate. It might be possible for those people to then go on to sort of daily rapid antigen testing plus or minus PCR testing, so they can continue to work. And you can imagine for some clinical groups where there are, small numbers of clinicians or staff available, that's quite critical, and I suspect that'll be very relevant to general practice. CDCB are just sort of working through how that might be part of the process. And then risk stratification of patients in emergency departments and possibly in general practice, where you may choose to use rapid antigen testing as a way of triaging potential positive or negative patients, and they might go through slightly different pathways. As I mentioned, they're good, but they're not perfect. Obviously, they're single use, so it's not a scalable test that has proven so well with what we're doing in the laboratories. Rapid antigen tests do not inactivate the virus, so the cassette, if it's a positive, is an infection hazard. One of the things that's been discussed is the recording of results and then the communication of results. We've developed some software so we can record the patient's details and then have a direct feed of those results directly to the CDCB, and that might be quite useful in clinical settings. It probably won't work once this gets out into the broader community. And as I mentioned, all positive tests are presumptive. You have to do PCR confirmation. Unfortunately, the buffer that's used in the rapid antigen test would inactivate PCR, so that you can't use the same swab. You have to take a second swab from your patient. And if you're doing rapid antigen testing, you've got to think about, now, how do I manage a rapid antigen test positive patient while I'm waiting for the PCR result? So the truck drivers are in their trucks thundering down the highway when we get the result a few minutes later, and then the CDCB contact them, and the police sort of assist with that. And at the airport, any minors that are positive, we isolate to a separate room. That's quite important. And the other message that we're going to have to communicate out to patients, this is not an alternative test if you're symptomatic. So if you're symptomatic, you really need to have a swab for a PCR test. Otherwise, we'll have a whole lot of false negatives out there. And then I wonder if that'll play. So this is just maybe, did we go back? Don't know if that's going to...
Let's see if we can do it outside of the slide, maybe. If we exit out, let's see. Slide now.
So full screen, you have to go full screen, I think. We won't. Okay, so.
It didn't look like it was linked. We can have a look at it and find it during the Q&A.
Anyway, I think the message from that is that they're actually pretty simple to use. The swab's a mid-nasal swab. It's not that deep sort of nasopharyngeal swab. The swab's placed into a tube with buffer in it, and the swab's just washed in that buffer, and then you drip 5 drops out of the little plastic tube into the cassette, and it runs. It's very similar, of course, to a pregnancy test, same sort of technology, the immunoassay, and then you get a control line and a positive line if it's a positive case, and the running time's about 15 minutes. So it is a little time consuming if you're looking to do large numbers of people.
We can certainly share the link to that recording with the webinar recording. Sure. If you should send that through.
Wonderful, thank you, Tom. So I know we're all quite interested in antigen testing, but I think it's quite clear as well. There's still a very strong role for PCR-based testing based on the stats that Tom just presented. So we'll move now to, and then we'll have a Q&A at the end. We'll move now, and noting that Mel's been very busy on the keyboard responding back to your questions, so keep them coming through. We'll move now to Jenny Gould, who is online. Hopefully we can see you, Jenny. We'll put your fantastic presentation up online there. now.
Jenny, you just need to unmute yourself. We can't hear you.
That is often the best way to hear me. But hello, everyone, and great to be on board as we prepare for the next phase in our crazy COVID journey. As you know, I'm the clinical lead for the GP assessment team, and so we've managed quite a few COVID positives both in the home and now in the Medi-Hotel system. So tonight I'm just going to share briefly with you my experiences and understanding of the management of COVID-19. So can we move to the next slide? Yeah, good. This evening I'll run through the clinical course, the predictors of disease progression and the COVID management strategies currently being considered. So the clinical course, you can go back to that previous slide, please. The clinical course of COVID is highly variable and not particularly predictable. So the incubation period is usually around 2 to 5 days. It can be longer, and we've seen that especially with Delta. The day 6 blues is a frequent time for deterioration, or also around day 8 to 10 with the cytokine storm, which anecdotally I haven't seen so much of with the Delta strain. Most patients are reasonably well, as Emily said, and children and some adults are often completely asymptomatic. And these, along with those with mild symptoms, are managed without any specific treatment or acute care. And this group does make up the majority at about 85%. For some, COVID is like a flu or a really bad flu as opposed to man flu. And this may need additional care for symptoms like fever management, analgesia for myalgias, antiemetics, oral electrolytes, even IV fluids. And this is probably around 10% of the cohort that need that extra care. And for others, they experience a severe illness requiring acute services review and often hospitalisation. And with other treatments, far things such as oxygen, ventilation, dexamethasone, antibiotics, etc. Next slide. The demographics and past medical history provide the best indicators for disease progression, or those who are most at risk of deterioration. We're all really aware of these now, and I've just listed them here. Of significance is age and comorbidity, particularly noting respiratory or cardiac disease with an odds ratio of 5, and also diabetes and smoking. So with regards to those who've tested positive and are displaying symptoms, those symptoms that are predictive of disease progression are shortness of breath and rigors. So shortness of breath or dyspnea is the biggest risk indicator in my experience. If there's any shortness of breath, then respiratory compromise has most likely already occurred. Clinical measurements are important, and these require equipment which is currently provided and will continue to be so as we manage these people again in home quarantine. We're looking at temperature, oxygen saturation, pulse rate, respiratory rate, blood pressure, and there are identified red flags for these clinical measurements, such as oxygen saturations dropping below 95. Next slide. Supportive measures are, as is the case in all viral illnesses, which as GPs you are absolutely fabulous at managing. Mental health is one of the largest health burdens seen with COVID during and after the illness, and much support services are in place, but the role of the family GP will be invaluable, and yet another area where our GPs shine. There are other issues which are not so much about the medicine, and some of this has been raised in the chat already this evening, but they're still very important as these patients are in isolation for at least 14 days. So that's around caring for others, children or other dependents, access to necessities like food, medication, bill payment, internet, etc. And we've supported those people last year at home and provided access to all of those services. So most people are managed out of the hospital system, but when to escalate care? As we said, a small percentage will deteriorate and require acute services. In South Australia, our aim has always been to transfer to hospital before deterioration, and not, letting people get very ill. As our numbers increase, so will our demand for assessment and acute services. And Emily has already taken us through the modelling, which is being put in place to accommodate these numbers. Excuse me. Next slide, please. So, what are the specific treatments currently available for COVID? And there are 4, and this information is up to date as of today, as I spoke to infectious diseases. The main issue is supply. So currently the only one in stock in South Australia is Sotrovimab, which is IV. We've also got ritonavir, which needs to be given with Pfizer 732, which is oral, Ronapreve, which is IV, and Pyrivene, which is an oral medication. Next slide, please. So Sotrovimab has provisional approval. It's an investigational human neutralising dual action monoclonal antibody with the activity against COVID-19, which is what we want. And it's indicated in the treatment of mild COVID that is likely to progress to severe disease. So the clinical criteria around this is adults who are within 5 days of symptom onset, they're not needing any oxygen, and they're not fully vaccinated, and that they have one or more of the risk factors that we talked about earlier, which are those that indicate the likelihood of disease progression. It's given by IV infusion. We certainly have some in South Australia via the rare current times. Next slide. Ronapreve, there doesn't seem to be a lot around information around this. It's another treatment to be given provisional approval, but we don't have any supplies. It's a monoclonal antibody cocktail of a combination of 2 drugs, and it's designed to produce resistance against COVID-19. Works very, very similar to Sotrovimab, but as I said, there's currently no stocks, and so its role is yet to be formalised in SA. But it does show some good promise. It showed about a 70% reduction in the likelihood of hospitalisation or loss of life for COVID-positive patients. So it is certainly can also be considered to use in patients who've been exposed to COVID and are unlikely to be protected by vaccination because of other comorbidities or are unvaccinated, but it clearly isn't recommended to be used to replace vaccination, despite Donald Trump's poor role modelling of such. The third one is the oral antiviral candidate for post-exposure prophylaxis. Again, so this is the combination of Pfizer 732, so we need to move to the next slide if we can, and it's co-administered with ritonavir, so which is an HIV antiviral that inhibits hepatic metabolism. The otherwise, the Pfizer 732 would have a very short half-life of only about 3 to 5 minutes. So it's oral, which makes it very promising to use in asymptomatic COVID positives or even close contacts. The research from other combinations with Levemir showed that it was ineffective in COVID, but found to be great for HIV. It seems this current combination is thought to be more effective, and Australia apparently has ordered about 500,000 doses, but currently no supplies in SA. Next slide. The last one is Pyrivene, which is undergoing clinical trials, and there's great excitement in the infectious diseases world about this one. I've added all the clinical trial details here for you, but as I realise that we're standing between you and your dinner, here's a summary I prepared earlier. So if we can go to the next slide. It's again an investigational oral medication that inhibits replication of the virus, and it's reported to show a 50% reduction in hospitalisation and death in patients who were not hospitalised when they commenced the medication and had mild to moderate COVID with at least one of the risk factors we've talked about previously. So the Move Out trial really showed that there were no deaths in this group that received the drug, compared to 8 deaths in those who received placebo when they followed the group through to day 29 of the illness. The Australian government has pre-purchased, I think, about 300,000 doses, but there's, again, currently none in SA. As it's an oral medication, if we can get supplies, it might be an area where GPs may possibly play a role. Next slide. So that's a brief run through the management of COVID as I see it. And we all know it's an ever-changing landscape, so we need to be prepared and agile in our clinical responses, not in back bends and cartwheels. But I just also wanted to use this opportunity to say a huge thank you to everyone who's been working so hard to keep SA safe, and our hardworking GPs out there, and also to my amazing GP assessment team for all their fabulous work. I'm happy to be contacted. I've put my details on the chat and they're on the screen. Back to you, Emily.
Thanks, Jenny. And I saw that Jenny's put out a recruitment as well. So if anyone is interested in joining the GP assessment team, please contact Jenny. I know a number of you are already online who are part of Jenny's team, and a big thank you as well to Jenny Biggins as well, who's also online, who does a lot to support Jenny as well in that space. But yes, it is an evolving area, and we absolutely need more GPs on board to support this centralised process around managing those acute symptoms of COVID and those referral escalation protocols as well. I know there's been different calls and bits and pieces coming through the chat around the usual GP, and I know Jenny's done a great job, and I know Mel's a very big advocate of this as well, is making sure there is very good communication with the usual GP, because as Jenny said, with all of the COVID issues going on, we know that mental health is one of the biggest issues and biggest problems with people who are suffering from COVID, because of the impact it has not only on their ability to go out and work and get on with life, but also longer term as well. And I saw a quick reference to long COVID pop up on the screen before. So and thanks, Rob. Robert Mans is also posted as well. So Noah does a fabulous job of looking after many of our positive patients in Tom's Court. Thank you, Jenny. So we'll hand over now to Chris to give us a bit of an update on the national issues and really where we're heading. Thanks, Chris.
Yeah, thank you, Emily. Look, I'll just run through some things you probably know already, but some of you don't, and you need the resources. So the first thing is, so I'm not generally a target subgroup, so I sort of see what's happening. But the first one is this issue about the clinical advice on the use of a different COVID-19 vaccine for the second dose in special circumstances. So, I mean, there have been some people coming to me saying, well, I've had a reaction to the first one, or else I've had one overseas, and how do I get the second shot? It's not available in Australia. You need to go to this document. This document is very helpful. It tells you, for example, if you had a reaction to a Pfizer or an AstraZeneca, or you've had a single vaccine in a different country, what you should do in those circumstances. And you definitely can switch vaccines in those situations. So many people have had AstraZeneca that are a known serious reaction, and the GP can make the decision on this. You are allowed to make the decision. You don't have to defer to a specialist clinic to do it. It actually, we made this specifically to allow you to do this. So for example, obviously if somebody's had TTS, but if somebody else has a clear reaction that is related, that's serious, that's been enough that you've reported it, that's the important thing, and you've reported it to the TGA or the normal reporting services, and it's clearly associated with it, may be likely to occur in the second shot, you can switch the vaccine. So AZ to Pfizer, Pfizer to AZ, and the other way around. Right, so that's important to know. So have a look at this document, it's very clear. So the second thing is sorry, I think there are a few people without muting. Could I just get you to mute your, because we're just getting to hear a few copy machines going off at the moment, which we understand why. So the next thing is, look, I can hear the discussion, and it's very clear in general practice, but it's right across health, these issues about furloughing, and it's a very serious problem, because in Victoria and New South Wales, a number of not just hospital staffs and hospital wards have been taken out, but also general practice as well. And that everybody knows that we've got to be kept there. Now, we understand that in an endemic COVID situation, the rules change, and we have to be realistic, because we can't have a situation where everybody's knocked out. Now, there is work going on this. I think this is the first step, and this is called the Work Pressures and Restrictions Framework for Workers in Healthcare Settings. It's really not really for your things, for policy makers to develop, but it gives some idea about how the thinking is going about determining people, basically determining, you know, the nature of the event of a contact or an exposure with the characteristics of the individual, for example, whether being vaccinated, how long the exposure was, frankly, how important they are and how rare they are, and whether what their circumstances is, and putting those together to determine, you know, the sort of how long they should be taken out of play, essentially, or furloughed, or whether they need to be at all, or whether some sort of rapid antigen type testing or regular testing could be put in place to mitigate the risk of that individual. Because we do understand at the end that, you know, we can't have a situation where everybody's out, because has to be people providing care. So there is work in this area. This document is a bit way over the top. You have it for some 13 pages of light reading, but it's certainly for people like Emily and people like that to start to make this practical in the medium term. Because we understand that for general practice, the issue is that if you get it, you know, the risk is it's both risk to you guys and all your staff, but it's also a risk to your patients in terms of not providing care, but it's also a financial risk. It's a massive thing, and general practice does not have that backup of you know somebody to pay the bills while the clinic is closed. The next one is this third primary, the booster, the sort of third primary dose for those immunosuppressed. For those who have not seen this already, please go to this document. This document clearly lists a box 1, which actually has very clear setting out of all the situations where those who are immunosuppressed should have it. It's not one of these things you make up. It's very, very clear as to those situations that have a third dose for a primary dose. So it's not a booster dose, it's a third dose for a primary dose for those who are actually immunosuppressed, severely immunosuppressed. So go to this document if you can. Look, just want to clarify the children's situation, because there's a lot of like over the top discussion about the children's situation. So essentially, if you want to do some good reading, these are documents to go to from the Murdoch Research Institute, Children's Research Institute. They've really come out with pretty much conclusive evidence that COVID, and that's Delta, causes severe illness and hospitalisation and death in extremely rare circumstances in children and adolescents. That is quite clear that that's the case, and it's the same with Delta. The only problem with Delta is Delta's more infectious, so more the kids get knocked out at the same time, and that means there's a higher number at a particular time of them ending up in hospital. So ultimately, it's no worse in terms of how sick they get. Long COVID is also very rare in kids. It doesn't really tend to persist beyond 3 months. So the issue is, currently the next thing is the vaccination stuff that's going on. So certainly at the moment, the TGA have a determination at the moment looking at the vaccination, particularly in 6 to 11-year-olds at the moment, but there's a bit of work to go on. It's not been approved. It's not been approved in America at the moment. Basically the overall situation with children is it doesn't make them very severe. They very rarely die. The risks of the vaccine look pretty good, although there is that small risk of myocarditis, which is why the Pfizer dose is probably a third of the dose that we've got now. The final thing is that ultimately the main reason to vaccinate kids, even 6 to 11, if you want to talk to your kids, is because they'll get infected and schooling's going to get interrupted, and that's a really big issue. And having our schools having outbreaks is a big issue, and that has a huge consequence for the community as well. So that's the main reason to vaccinate kids. Now, it's just the national issues, which are related. So the booster issue, just to relax, Targia right on top of it. The government, the federal government are really gearing up to go with this already. So they just need to get this done, including working out, they're trying to smooth this out because they've learned that the big thing is all this criteria rubbish, A, B, C, D, you know, it's just going to go. Essentially, what's going to happen is it's got to be much more, boosters are just going to be probably by time based essentially, and it's just going to be everybody. And it'll be how long since your previous vaccine. They just don't want to have these criteria anymore. So they want to smooth it out. They'll smooth out the funding as well for general practice. It'll be none of this, you know, all the bits that go together at the moment. We're not going to get a windfall, but my thinking is it's going to be just smoothed out. So it's equivalent, but just none of this, all the bits and pieces that go with it at the moment. But there is a lot of thinking in this area already going on. So just to be aware. So the main things is now we need ATAGI to make a call on this, but ATAGI are going to be probably affected by the situation. We're going to have a surplus of vaccine pretty soon. We almost have a surplus now, so we don't want to go to waste. So I think that they're going to come to this pretty close. But again, what will happen is I suspect is it'll be by time. So it'll be how long since your last vaccine. And the reason why that's the case is that the ones who are category 1 in the first category are going to get the vaccines early anyway. So just to give you an idea, it's coming, don't worry, it's going to happen, I think, very likely. COVID vaccine for children, again, is going to be lined up pretty quickly, very likely. So the department are ready to go with this. They just have to, ATAGI have to make a call on this. The biggest problem with this 1/3 volume thing, which is a huge issue, it's a 1.1 of a mil on a 0.3. It's a really logistical issue. But that is coming at the moment, I think, and so get ready for it. But again, the department are ready for it. I must say, the Department of Health federally are extremely grateful to general practice. There is actually look at the numbers. General practice have done most of the vaccines. It's quite clear, and in fact, they're so keen. They've been so impressed by it. The need for school-based vaccines for COVID is looking less and less important, and actually, general practice just getting on and doing it. So, well done to everybody. There's a real appreciation of the effort of general practice. I think general practice has done 19,000 out of about 19 million out of about 32 million shots. Not just general practice, but general practice by far the majority of that. Moderna, I know people have been wondering about Moderna. We're not going to get Moderna unless we get heaps of supplies later. The reason why was mainly because of the logistical issues of having another group of people delivering, and it was just cleaner and easier for this. And to be frank, Moderna is looking a little bit easier for general practice actually at the moment, particularly with some of the issues with the children. We're going to go for Pfizer's going to be children first, and also the issues. There are some issues with the myocarditis being somewhat higher because it's just a higher antigenic load with Moderna, and that's why there's appears to be a higher rate of myocarditis with Moderna. That's why you get higher coverage for longer, but that's probably why you get higher myocarditis issues. But look, it's still extremely rare, so it's not something to get too worried about. The COVID vaccine indemnity scheme, which I was involved a lot in, we sweat a lot of blood on that, so that's actually been really important on this. So it's something which has been really critical, I think, and hopefully the prelude to something for vaccines in the future. But we've got to do a bit of convincing of government about that. But this is the first time that's ever happened in Australia, so we sweated a lot on this to get this through. Look, I know a lot of you have been really worried about the effect of telehealth on the standardised whole patient equivalent thing, swappies and the PIP. Now, that's really been more of an issue in the eastern states where they've had to go to telehealth. So a lot of people and GPs in telehealth have gone, oh, gee, this is not fair. We're just doing telehealth, and because of that, they don't get counted for the swappies for the PIP. And then there's been a lot of angst about that. Can I just say that is actually not true? Essentially, the thing is the standard whole patient. So what they're saying is that because of that, they don't get paid as much because those visits don't get counted. That is not true. Essentially, what actually happens is that the swappies are based on whole patient equivalents. It's a set amount anyway. So there's no more, no less. The thing is that the swappies are based on face-to-face because it's going to favour generally the practices are going to provide face-to-face. So there's a bit of a discussion about whether telehealth visits should be counted to the swappies. But the government are reticent to do this because they want to favour practices that stay open and do face-to-face, because really they're normally the usual practices. What we don't want is essentially only practices that do telehealth being favoured in this whole swappy thing and the PIP favouring. So just to understand the background to this, standard whole patient group is a set amount anyway, and so that is why the addition of telehealth shouldn't make a lot of difference to practices who are providing face-to-face and telehealth to their patients on a regular basis. So the other thing is, so we worked very hard to get extension of image-based prescribing and the subsidy for SMS tokens. So you're not paying for the SMSs for electronic tokens. And the reason why that's been extended to the end of the year, because we understand that we've got to get to active script lists, which is the other way. So active, at the moment, we're sending out these tokens which are sent to the patient, and then unfortunately have to be sent to the patient at the moment instead of the pharmacist. But what will happen is it'll be hopefully a lot simpler by the end of the year when active script list comes along. So essentially what will happen is you just approve the script at the practice. It will actually essentially approve it in the cloud that this has been approved, the patient should be able to see it on their app on their phone, but there's no tokens. What will happen is they just have to link up with their practice, have given enough ID that when they ask for it from their practice, from the pharmacist, that the pharmacist can identify them. You're given consent to actually look at the active script, and then they'll be able to then be able to dispense it based on what's up in the cloud-based script list. So there won't be any of these tokens. There'll be some virtual tokens, but it won't be really a token mechanism. And the reason for that, there won't be need for SMS then, and there'll be no need for any payment or subsidy of SMS tokens at this stage. So it'll be a lot more simple at that stage. The future of electronic prescribing, which is what I was just going on. COVID care in the community. So look, we are trying to get involved to try and see whether the Commonwealth will come to the party on this to help practices in terms of the COVID care in the community. Look, the bottom line is that if you've got 85% of all people are just going to have a cold. They're going to be double vaxxed, they're going to be low risk, they're going to be a cold. And you can see that overseas, that it's just a cold. It's when they've got social risk factors or high risk factors that are issue, but even for those ones who are low risk, they just need a line of being able to get help as soon as possible if they deteriorate. But we do need general practice to be able to continue providing care for them in terms of telehealth for their normal other care. And that's the sort of work that's going on here at the moment. With respect to the next group, that's where it's going to be a bit more hospital and home type sort of care. And then there's going to be the other bit. Now, our issue is that it's not just about care of COVID, it's about other care, being able to provide face-to-face care in the community while there's a endemic COVID situation without hopefully having to close down all the time. And that's going to be the big risk and tension for us. But all I can say is hopefully we can get some more support both from Commonwealth to mitigate the risk of getting COVID into our practices, but also help us, support us to protect ourselves a bit more, and also be able to provide normal care by telehealth as well when COVID starts to enter our community. It's going to be that balancing act at the moment, and that's what's hopefully going to come out a bit with this COVID plan, but also the Commonwealth funding side of things. Okay, and final thing, Health Pathways SA is going to be really important in this, so you'll start to see that. I always mention Health Pathways SA, massive conflict of interest in there, but it's going to be, in every jurisdiction, it's going to be really important to set out the actual pathway for management for COVID in the community. So thank you.
Thanks, Chris. Excellent. So a lot of work happening in the national space. And I think we really do need a lot of advocacy at the Commonwealth level for a lot of change in this sort of space, and particularly around the funding as well. So Chris has been working very hard on that, but we're also advocating at a state level as well for a lot of changes for further funding for general practice, and particularly through the national jurisdictional meetings that are held once a week that now seem to be picking up on the primary care, which is really great to see as a subcommittee that's been set up. So we'll go through now through questions, and I think there's been quite a few questions, Phil. Yeah. We can't read. We haven't been able to read the questions, but we've certainly seen that people's names have popped up on the screen asking things. So we'll start with some of the areas.
I might actually start with the first question to Tom. There was a question around how much is the rapid test and how much does that PCR cost?
Right. So the cassettes, depending on the manufacturer, are around $7 or $8. Some are more, some are less. Laboratory PCR tests are more like $30.
And then there were a number of questions around the model you presented at the start, Emily. One of the early questions was what will be the resources for patients with long COVID, and will there be specialist service, which kind of follows on from that immediate acute management pathway. So I wasn't sure if you wanted to comment on that.
Yes, absolutely. So, and Jenny, feel free to come in here as well. But we did see quite a number of issues, particularly in the first wave with long COVID, and particularly the follow-up required from a cardiac point of view as well, and the complications for people post their acute COVID period. So far, the evidence that we're getting, really that real-world data coming through, is we're not seeing the same picture that we had previously with long COVID with vaccination. And we're really hopeful that that will continue in where we see things moving forward. But there is work happening at a national space around long COVID and monitoring and following up people. Jenny, did you want to comment at all on that aspect? You're on mute, Jenny.
You're on mute, Jenny.
Thanks. Yeah, well, within the GP assessment team, we are really only seeing them for their COVID journey. But of course, the number of these people we've kept in contact with over time, and some I see in my rooms in general practice. So yeah, there is an issue around long COVID. A lot of issues are mostly around mental health, but there are some people who see that sort of long COVID or post-viral fatigue and reduction in exercise. And so I think there things that on the whole we can manage as GPs, in that we can exclude other issues. You know, they might need an exercise test, you know, they might need a chest x-ray, that sort of thing. So there are certainly things we can do as GPs in that space, but there will be a small group, I'm sure, that we will need extra input from if we see that problem with the larger numbers.
Yeah, thanks, Jenny. And I know there is national work happening around health pathways for long COVID follow-up as well. So that will be very helpful as well.
We also had some questions around how rural patients will work in with GP assessment teams as a rapid response teams, and how that's going to integrate.
Yes, so there's work happening currently with the local health networks out in the regions around support that can be provided from both the community nursing point of view and also from an LHN ED perspective to provide support into the communities. But we do have our GP assessment team and a number of rural GPs who work as part of the GP assessment team, and we would hope that more rural GPs would want to join the assessment team, noting that we will have a centralised GP response out, particularly in those areas. In terms of the assessment centres, there's a lot of work happening in the assessment centre space, and looking at the roles of the GP respiratory clinics as well moving forward, and also in the LHN space around regional hubs that can be developed to be able to undertake that assessment and then provide the treatment as well. As Jenny mentioned, there is a lot of work happening. There's a lot of doses that the Commonwealth secured for us in the antiviral space as well. So we're really hopeful with the monoclonal antibodies that we'll be able to really reduce down that risk of hospitalisation by using some of these newer interventions that we've seen great success so far in the US with.
And obviously, questions that's at the top of every GP's mind is, how do we make sure that our practice is safe? And we've talked a little bit about in the chat about how we're working on developing an exposure matrix kind of guide, a bit like that which was released in Victoria a week or two ago. It's in process and it's coming, and we totally understand the critical need for this. And there was a specific question about how that those kind of issues might apply in aged care facilities now, particularly now given that most residents are vaccinated, and how outbreaks might be handled in those facilities.
Now, it's a really important area. We know it is one of the high levels of anxiety, particularly for practices and practice owners, around what happens to the practice if they have a positive patient come into the site. And we certainly see it all the time on Facebook in different forums and GPDU around the concern that this has been for many practices, particularly in Victoria, where it's taken considerable time often to have a response back from the Department of Health around what needs to happen next. So as Mel said, work is underway to replicate the hospital-based guidelines that have now been endorsed here in SA into the GP space, to be able to help both GPs but also other community settings as well, how to manage if someone does come in with COVID. What I can't stress enough here is the role of N95s and fit testing and fit checking the N95s. And the reason why I emphasise this, and this is the reason we've often seen practices close interstate, is because staff have not been wearing N95s and they've come in close contact, and therefore their staff have then been furloughed and been unable to work. Now, we're seeing some really good progress now around the 7-day quarantine period, and particularly that was endorsed at CDNA at the national level to move to a 7-day quarantine period for close contacts if they are fully vaccinated. And we would hope that we would have a similar position here in SA. We're not quite there yet because we don't have community transmission here. Therefore, our baseline risk is slightly different than what it is in the eastern states. But there does need to be greater work in how we can make sure that staff are safe. And it's a good question. I've just see the top bit of that question that popped up there on the screen around the cost of N95s and how do we make it more cost effective for our staff. And this does come back to how can we ensure that we have stock available through the national stockpile, but also through local supplies as well out to GPs around N95 usage. But we're very hopeful that with full vaccination, we can move to a position where staff can be have a negative test and then return to the workplace is where we hope to be. And certainly that's the position that's been taken in the hospital space as part of the guidelines. So lots of work. Mel's working very hard with CDCB to get progress in this space, to be able to come up with a really key guideline for general practice. And we've been hearing the feedback and we're keen to make sure we do have something. We're just still waiting on some of these positions to be landed.
Absolutely. And again, the questions around fit testing and access to PPE, we're doing our best to try and find ways to get it to GP practices cheaper and more easily without people having to shop around a million different providers. So we're looking at ways we can sort of leverage large purchase pathways to minimise cost and doing whatever we can to try and get through those resourcing issues. And around fit testing, if anyone's having trouble accessing fit testing, please get in touch with me via the GP liaison email address. We certainly have been working closely with the PHNs, particularly in rural areas, and with our LHNs in rural areas to see where we can utilise the existing resources for fit testing there wherever possible. So if you're having trouble, particularly in rural areas, let us know. And there are an increasing number of private providers in Adelaide who are able to do that. And we're looking at potential alternative methods just to make it more accessible.
And I think, Mel, just adding on to that, I don't know if anyone else wants to comment on this, but just around the N95 usage, we know that there is absolutely, when we have COVID cases here in the community, that a number of GPs will revert to telehealth and not have see people face to face because of that risk that we know is posed by having community exposure, which is one of the key reasons why we've got the respiratory ready GPs as part of our structure. How can we make sure that people are being seen in the most appropriate place, utilising PCR testing before people then come into practices to be assessed? And then, of course, having people in the home environment with services delivered in the home rather than getting people out in the community when we know they're already COVID positive. So there's lots of work underway to try and reduce the number of risk factors that then come into general practice. But we do absolutely acknowledge around the cost is quite prohibitive from an N95 perspective. And we have tried to supply out of our SA health stockpiles at this point, but we're getting a few barriers around some of we may get some health commission complaints and some complaints coming through if we start distributing out of our cost price. So we're just still working through a lot of those issues. But we're very keen, Mel and I are very keen to make sure that you've all got access at reasonable costs.
We had a question that Jenny might be able to answer here around from Oliver, around is pneumococcal pneumonia something that you see happening in people who have COVID, similar to what happens to some people who get influenza?
No, I'm not on mute. Look, honestly, we've seen with COVID, we've seen such a small number of other infectious diseases in the current climate with all of the restrictions and things in place. So no, it's not something that I've seen or that I know about, but it would make perfect sense if you've got someone who's already has a severe viral illness. They're going to be immunocompromised and more at risk of catching other or being exposed to other things. But it's not something that I've seen or heard of. Anybody else? Emily, have you got any thoughts?
No, I'm certainly not aware of it, but we do know that people's immune system is under significant pressure post-COVID infection, but I don't think we have enough data to support that here. But maybe globally we might be able to get some more information on that, Oliver, as well. Thanks, Mel.
There are a couple of questions around vaccine as well. There was one question I think Jenny posted on behalf of someone else around utilising leftover Pfizer doses in rooms. Could these be used as a booster dose for medical or nursing staff? And I think I would caution strongly against doing that because it is not consistent with the target guidelines currently. There's no guidance around using boosters in anyone, only the third dose as part of a primary course for people who are immunocompromised.
And there's just not the evidence to support it. I can't, we have Professor Helen Marshall sitting as part of our strategy group around vaccines here in the state, and there is not the evidence to support having booster doses given to otherwise well, healthy people. Just
basically, you get 2 shots. You're not going to die. That's the bottom line. And essentially, that's the thing. What will happen is COVID will be a condition of the unvaccinated. They're the ones we've got to get them into. The reason why they won't shift at the moment as well, and there's been discussion about the use of these, is essentially the concern that it'll become carte blanche without really clear evidence at this moment in time, that people will open up an extra bottle and there'll be another, there will just be, it'll go out of control. Because we're still in the phase, particularly in South Australia, of still vaccinating the people that need to get vaccinated. And we're really not at a stage where a large number of people actually need their boosters. But look, I think the boosters is probably going to come, is likely going to come, and just hang on, and there will be a clear policy at some stage.
yeah, no, that's very helpful. Thanks, Chris.
And there's some good discussion in the chat around how you can utilise leftover doses, taking them to a local shopping centre to find people who need some, that kind of thing, if need be. And so hopefully no one's needing to throw too many doses away. There was another question around, is there any information on when the vaccines will no longer be delivered in multi-dose vials? And I know I have not heard anything around that, and I think it would be a ways off at this point.
I'm just asking if anyone's on mute, if that's all right. Just getting a bit of feedback. Thank you.
I think too, it's important to remember around your doses when you're ordering your dose allocation. If you have stock left over, you don't have to order your full dose allocation. I know I think there might be some concerns that in the early stages of the rollout, if you didn't order your full dose allocation, you'd actually be almost shifted down a tier and your dose allocation through the Commonwealth would be lessened. That's not the case anymore, and we can certainly advocate, we can certainly get you increased if that was to happen, and we can certainly support you with accessing more doses from the Commonwealth if you need to, but I think it's important to remember to only order the doses that you will need or that you've got planned clinics for. And if you've got 500 doses left in your fridge, don't order another 1,000 if you know you can't use them because you think that you have to. You don't order your lower amount, get through those and then progress from there. And certainly if you need assistance in moving some doses to other practices, the PHN, your practice facilitators can support that. We're doing a lot of work moving doses to GPRs or CDCs and different practices in which may, excuse me, for whatever reason, be a little bit short of doses. So please reach out and let us know. We certainly don't want to see doses going to waste. AstraZeneca is certainly a lot harder for us to move at the moment, but Pfizer doses we seem to be able to find another primary healthcare provider, metropolitan practice, to take hold of those. So Seema, can you just flick through an email to your practice facilitator tomorrow and let them know that, and we'll see what we can certainly do for you around accessing those excess doses.
Thanks, Crystal. And just to add on to this around vaccination, I know we had a couple of questions posted around mandatory vaccination of healthcare workers, and this is quite a topical area, and we met again today with various individuals around progressing this direction. So for those of you not aware, there was a recommendation from AHPPC to go to National Cabinet around mandating requirements for healthcare workers to be vaccinated, and this included GPs, pharmacists, dentists outside of the hospital space, and that position was then endorsed at National Cabinet. And certainly the intention here in SA is that that will be in a direction. We've just had to work through a few different legal issues around how that exactly is worded in the direction, which is why it's taken a couple of weeks of back and forth drafting of this and really clear Crown advice and ensuring that we're not opening up people to risk. And what I can't emphasise enough is opening up practices to risk for employees within your practice to risk. So it is really important that we get this right, we get the wording right, and we also ensure that the direction under the Emergency Management Act it is really quite clear and is pretty strong. It's very, very strong from a legal point of view. So we're still planning, it'll be on the 8th of November that we're expecting that this will be a mandatory requirement for GPs and GP clinics to meet the vaccination mandatory requirements, but we're still working through that. It could end up being further delayed if there's some further pushback or further legal concerns raised. But the other states have all moved on this, so we're just still working through that at this point in time.
Is that correct? The way it's worded though is that it's actually worded that it's the onus is on the individual,
Yep.
not it's the individual working in that place. So this is very important because it does mean it's a little bit less of a problem for the employer as the employer. It's the responsibility of the employee to be vaccinated and to comply. So that's one of the critical things which hopefully will give you a little bit of assurance, because I think obviously there has been extreme concerns at every level about the whole industrial legal aspect in every area, aged care everywhere, and that's why there's so much work to try and make it as clear that the onus is actually on the employee and less on the employer, because it's a bit unfair for the employer to be caught in this situation.
We've been really trying to emphasise that it does come back to the individual, and that protects them, the employer, from that legal point of view. To add on to this as well, around the medical exemption process, there's still work underway in this, that it is mirroring the no jab, no pay, no jab, no play concept as well, that does have that requirement for people to have the Chief Public Health Officer endorsing that level of exemption. So I think we've seen maybe one come through so far that's met requirements. There's been quite a significant number that have come through that do not meet requirements. So it is really important to refer to that ATAGI advice. It's very, very narrow, the criteria for exemption. And this, I guess, provides a little bit of push. It provides the opportunity to push back on this as well. But we have seen a large number of exemptions being given in the other states, and the decision was made here that we would just follow the ATAGI advice.
So there's two bits. There's the normal advice, which is for all vaccines, which is on the air exemption list, and then there's a separate ATAGI temporary, and that's only for temporary anyway.
Yeah.
So it's very narrow. It's not because you're feeling a bit sad on a day, that just doesn't happen. So just be aware. So if you're really worried about it, I'll print both documents out, show the patient and say it's just not going to happen, because I know that a lot of us have been under pressure on this issue.
Yes, and I think we had 3 or something yesterday that came in for a baseline on anxiety around being vaccinated, just to emphasise that it's not it will not be granted an exemption on that basis.
There's also a question as to whether the direction will extend to carers in the home, caring for vulnerable elderly and disabled clients. Will they also come under the mandated vaccination, even though they're not working in a healthcare setting or facility as such?
If they're employed through the local health networks under the Healthcare Act, they are then required to be vaccinated. If they are working independently and not contracted through a hospital or hospital in the home service, then they are not at this stage. There is further work happening in the disability space and in the in-home care space to look at those requirements. It is difficult. It has to be, the risk has to be really balanced with the overall risk in a facility type setting versus the risk then of potentially infecting someone. So it is a bit of a balance between the two, which is why we've taken the facility or employed within a particular facility rather than it being in-home care based.
And there's also been a question as to whether the emergency direction will become enduring legislation at some point.
I mean, all of this is being looked at around what happens when we come out of the Emergency Management Act, and will absolutely need to be considered. We're not there yet by any means.
And I think we've covered most of the big questions, and I'm sorry if there's some that I've missed here. If anyone still has any particular questions they want answered, please feel free to email directly. I'll put my email address in the chat, so if you have ongoing questions, Emily or myself, we can manage those and forward them on to whoever you is best to answer them.
I've got a question for you, Tom, if that's all right. Just around serology, particularly around serology looking at vaccination status. I'll get a few comments coming through around this. People saying, I'm worried, I want to get the 3rd dose. A healthcare worker, I was vaccinated in March. Have you had many requests in that space at all, and what's sort of your advice for that?
So, surprisingly few requests, and the advice currently is still that's not a useful test. Obviously, serological conversion is high initially, and then the antibody levels fall away, but that's the normal physiological response post-vaccination. And of course, on re-challenge after 2 vaccines, the antibody level spikes very, very quickly. So it's actually not a useful marker of your immune status.
And just to confirm, with regards to the immunosuppressed, the target recommendations are you do not do a blood test for it. It's just very clear. Just follow the guidelines, give them a shot. And it doesn't have to be the same one. It's probably better if they don't. With the 2 AstraZenecas, it's probably better that they have the Pfizer at that stage, because the Pfizer will probably give them that combination. It does seem to be a bit better. And the thing is that there's a theoretical issue about having a third AZ because of the increased immunity to the actual adenovirus in the AstraZeneca vaccine. So those people, it's absolutely reasonable for people who've had 2 AZs to have the Pfizer for the 3rd dose of immunosuppressed, and that's probably what's going to happen for the boosters. It's just going to be a free-for-all in terms of what you get afterwards.
Thanks, Chris. I can see a few questions just come up briefly before around practice preparedness. So we will be doing a lot of work now around the planning of how we operationalise our COVID community model, which of course will then link in with how this works and with general practice being absolutely critical to this, and ensuring we have the health pathways updated as well around how patients can be linked in with those services, and the expansion of the GP assessment team and our rapid response care team, which sits over top of this as well. So we'll make sure that we come back and have another webinar where we've got a little bit more of those operational details sorted through, and we can come back with some more concrete information for you. But just want to say a very big thank you to all of our GPs here in the state. You do so much for us here, and really for your ongoing commitment as well, and the fact that you've turned up tonight to listen for an hour and a half and to hear where we're up to with our planning, our response, and the next steps. We're just incredibly grateful for your support. So, anything else further that's come through on the chat? We should be covering.
No, I think that everyone's keen for more webinars, more information.
Wonderful. All right, we'll leave it there then. So thank you so much to everyone here in the room, to Jenny online, to Crystal, Adelaide PHN for continued support in this space, and we look forward to reconvening soon and providing more of a COVID update for you. Thank you.